Hi. So I'm going to talk about obstructive sleep apnea today. This is in the series of sleep apnea YouTube videos. So this one is to know the treatment part of sleep apnea. We talked about various ways to diagnose it, which included a home sleep study, which is 4-channel recorder, or sometimes there may be something where you have some brainwave recording, and then the in-lab study. So now today we're going to talk about the treatment if somebody has obstructive sleep apnea. As I mentioned it to you before, less than 5 events of apnea hypopnea per hour is considered normal. 5 to 10 is a little bit of a gray area if it is associated with significant oxygen drop or symptoms of excessive daytime sleepiness. One could treat it. Then the 10 to 20 is considered as a mild. That means 10 to 20 episodes per hour is considered mild. 20 to 30 episodes per hour is considered moderate, and 30 plus is considered severe. There are some people who consider 15 to 25, 25 to 35, and greater than 35 being severe. Again, it doesn't matter. Once you have sleep apnea, you need a treatment. So the various options of treatment include a pressurized mask. It's called continuous airway positive airway pressure, CPAP. Continuous positive airway pressure, CPAP. And then variety of this is available. So this is probably the best treatment, effective 100%, but not tolerated by many. The alternative to this, which will be discussed probably in the next video or later part of this video, includes a surgical approach usually done by ear, nose, throat doctor called UVPP surgery, uvulopalatopharyngoplasty, and I'll talk about that a little bit later, or a mandibular advancement device which pulls the jaws forward, or dental or bite block as some people call it. These two are alternatives to it. The mandibular advancement device is effective only if somebody has a mild sleep apnea, not moderate or severe. And UVPP is successful maybe 70%, maybe less. And you have to have anatomic of your throat to be appropriate for it. But we will talk about alternative treatment of sleep apnea other than positive airway pressure, also called PAP therapy. So the PAP therapy, the machine generates a pressure and it is transferred to your upper airways, so that the upper airways, which collapses during the deeper parts of sleep or sleep, remain open. So there is no mechanical obstruction, or the obstruction is removed by the pressure. So this pressure could be continuously exerted throughout the cycle of breathe in or out, inspiration and expiration, or you are awake or you are asleep. And that would be called as C, which stands for continuous, positive P, airway A, P pressure. So CPAP, continuous positive airway pressure. The variety of this is also called a BiPAP or BPAP, as BiPAP is a brand name. It is a bilevel positive airway pressure. That's why it's called BPAP. In this particular, pressure is different when you're breathing in versus when you're breathing out. As the pressure is increased, when one has to exhale against a pressure, some people cannot withstand a high pressure. So when the requirement for continuous positive airway pressure exceeds certain number, a lot of people may have difficulty tolerating it. Under those circumstances, people use BPAP. So the pressure is higher when you're breathing in, lower when you're breathing out. Each pressure has its own treatment part, apnea versus hypopnea. And some people needed for central sleep apneas where the brain is not initiating the impulse. Again, the technicality of it is too difficult. Just to understand, CPAP is continuous positive airway pressure. BPAP is bilevel positive airway pressure, where the pressures are different in the respiratory cycle. The third one is called AutoPAP, automatic positive airway pressure. This is employed when we actually don't do a CPAP titration study in the lab, or when we do the study, we cannot come out with optimal, ideal pressure to eliminate the episodes of apnea and hypopnea. Then we use AutoPAP. So the AutoPAP is where the machine recognizes that the depth of the breath is reduced or it is zero and generates a pressure to open up the obstruction. As you can imagine, if there is no obstruction and it is a central sleep apnea, AutoPAP will not be effective as much as we would like it to be. So the machine has an algorithm based on your baseline depth of the breath. The machine would automatically start a pressure, and one can use certain limits of pressure. So a physician can put a range. So if I would give somebody an AutoPAP 5 to 15, the minimum pressure would be 5, the maximum pressure would be 15. So if the apnea or hypopneas are not eliminated by 15, patient will continue to have them even with the pressure that we are employing. So it becomes very important to do a follow-up of compliance, but also the follow-up of events. That means the prescribed therapy, whether it is effective or not. As you can imagine, if the apnea-hypopnea index after the therapy is less than 5, which is the ideal, it is the best controlled sleep apnea. If it is more than that, then people have gradation of it: optimal, acceptable, not very good type of things, based on what proportion of apnea hypopnea index you are reducing. Let's say somebody has 100 apnea hypopnea per hour and we bring it down to 10, versus somebody who has 20 and we bring it down to only 10. There is a difference. So the effectiveness of therapy depends on the pressure and the pressure tolerance. There are instances where somebody may have to bleed in or add oxygen to the positive airway pressure system. So again, this is titrated in the lab. So if the apnea and hypopnea are eliminated or substantially improved, but the oxygen saturation continues to be low, then we add or bleed in oxygen, which is bled through the same machine that generates the pressure. So now remember that the machine is same. So the machine which gives you continuous positive airway pressure is same. The tubings are similar, but the mask, which is airtight, is different for different people, and the patient has a choice to select a mask. There may be a mask which covers the whole face, especially if somebody is a mouth breather, or there will be one which just covers the nose. So the first one is called full face mask. The second one is called nasal mask. Some of them have a strap above the ear, below the ear. Some of them have a forehead support. And the other hand, the third kind is called nasal pillow. That means there are two nostril blocking nozzles on the mask, and it stays around the nose, and that generated pressure is transferred to the upper airways in the throat, and these are very effective unless somebody opens up the mouth and the air is leaked. So we'll talk a little bit about the different masks and effectiveness and the events and the compliance in my next video. Thank you for watching. If you like it, subscribe it. Have a nice day and a nice weekend.